So now we will be starting the last session of the INI 2020 PYQs. So here the first question is about this acid base nomogram, where we have to identify what is A and what is D. That's what we have to identify. So the simplest way to do is, first you have to check for the pH. See, this is the normal range of the pH. The A is on the acidotic side, so this is acidosis, and D is on the right side of it is alkalosis. That's it. Then next, in A you can see the bicarb level is raised, it is almost around 28, and the PCO2 level is again almost near 100. So in A we can see the pH is low, PCO2 is high, and bicarb is again high. So this is your respiratory acidosis. Now whether it is acute or chronic, we have to know that in chronic there will be compensation, the pH will be normal, whereas in acute there will be pH is not yet normalized. So A is acute respiratory acidosis. See, then next the D. So it is, we can see the pH of the patient is high, then we can see the PCO2 is 15, it is low, and the bicarb is also on the lower side. So pH is high, PCO2 and bicarb are low. So this is again your respiratory alkalosis. Again the pH is not in the normal range, that means the compensation has not occurred, so it is acute respiratory alkalosis. The answer is this. So you can just see in this this is the answer, the acute respiratory. See, in chronic respiratory chronic alkalosis, the pH is almost normalized. In chronic it is nearly 7.3, in chronic respiratory alkalosis nearly 7.4. Then in the metabolic acidosis and metabolic alkalosis, these are very simple. Metabolic acidosis, the bicarb is low, pH is low, and the PCO2, all three are low. In metabolic alkalosis, the pH is high, the PCO2 is high, and the bicarb is also high. So all three are high. So the most important point you have to understand in this is any acute there will be not yet compensated, it will be not be compensated. So pH will either be low or high. In chronic condition they will be compensated. So pH will be on normal side. These are the important points. Next, you should know the normal values. pH normal is this, we take it 7.4. Bicarb is 22 to 28, we take 24 as the normal value. PCO2 35 to 45, we take 40. Anion gap we can take around 8 to 10 as the normal value. Then coming to the PO2 is 75 to 100. Now this is the table of ABG. If we were to see for the VBG, there will be PCO2 in VBG will be little higher than this, and PO2 will be little lower than this. This is the only difference between ABG and VBG. Then the next is how to know the compensation. This is the only three compensation can be asked from you: the metabolic acidosis, the respiratory acidosis. Metabolic acidosis and respiratory acidosis. Alkalosis they won't ask from you. So in metabolic acidosis, the formula is this: PCO2 is equals to 1.5 times the bicarb plus 8 plus minus 2. Acute respiratory acidosis is increase in bicarb should be 0.1 times the increase in PCO2. And how to check for the chronic? Increase in bicarb should be 0.4 times the increase in PCO2. So these are the important formulas. So now let's try what does this all mean. So in the first case, the pH is low. We can see the bicarb is 26. So normal bicarb, let's take it 24. So it will be around 2. This is the change in the that means that there is increase by 2. PCO2 normal is 40 we are taking. Now difference from 92, let's take it 90. It will be around 50. So how much increase? It is almost 5. It is almost 50 or 15, almost 5 times. It is 5 times increase. So we have learned that if it were to be now for acute respiratory acidosis, increase in bicarb should be 0.1 times the increase in should be equal to 0.1 times the PCO2. That should be 5. 5. So but bicarb increase is 2, so that means this is not yet compensated. So it is partially compensated respiratory acidosis, and it is acute condition, because in chronic condition, as I have told, pH would have been normal. Now coming to the next case, pH is 7.3, bicarb is 41.2, so it will be 40, let's take it 40 minus 24, that will be around 16. PCO2 is 78, let's take it 80, that is 40. So here now it is compensated. Now we can see that this is respiratory acidosis, acute, which is partially compensated. Now this is chronic respiratory acidosis because pH is already normal. So we have to check whether it is compensated or not. So compensation in chronic is increase in bicarb should be 0.4 times the PCO2. So it is equals to, it will come at 16. And we know that increase in bicarb is 16. So this is fully compensated. So this is fully compensated. As we can see, the pH is almost normal now. Now coming to the last question, pH is low, bicarb is low, PCO2 is low. So this is your metabolic acidosis. Here there is no term like acute or chronic. We just have to see whether it is compensated or not. So it is, here we are checking the expected PCO2. It is 15, the bicarb into 1.5 plus 8 plus minus 2. This will come out to be 22.5 plus 8 plus minus 2, which is somewhere around 28.5 to 32.5. And the bicarb, our bicarb is 15, so that means that it has not, our PCO2 is 38. So we can see that there is a little, the acidosis is not fully compensated. This is metabolic acidosis with partial compensation. So that's it. So the thing that you need to know in this is this graph. This point that acute is the pH will be still in the higher or lower range. Chronic is compensated, this normal table value. Then these three formulas. That's it. Coming to the next question, the high anion gap acid question is asking us about high anion gap acidosis is seen in all of the following except. So any condition with which has acid in it will be your hagma. So methanol, ethanol, uremia, it is a kind of renal failure, acute or chronic. This will lead to acidosis, so much acidotic hagma. Diabetic ketoacidosis, lactic acidosis, salicylic acid. You can remember this as salicylic acid. So it has acid, ethanol, methanol are acids. Diabetic ketoacidosis, lactic acidosis. These two you don't need to remember. So this much. Then now only confusion that comes is with RTA. So RTA is your normal anion gap metabolic acidosis, whereas uremia is your high anion gap. So diabetic acidosis will be hagma, salicylate will be hagma, lactic acid will be hagma, renal disorders will be your nagma. And another question they can ask you is diarrhea. Diarrhea falls in nagma group. Now coming to the next question, patient with vertigo, diplopia, hoarseness. So this is about the brainstem syndrome, a very important topic. So here you have to remember these syndromes: 2 in the medulla, the Wallenberg, which is the lateral medullary syndrome, medial medullary syndrome, 3 in the pons, and 3 in the this midbrain. So coming to the first, the Wallenberg syndrome, which is the lateral medullary syndrome. The artery supplying the lateral medulla is the pica. All of these are MCQs. Cranial nerve involved are 9th and 10th, and the most classic feature is the Horner syndrome. There can be dysphagia, hoarseness, vertigo because of 9th nerve, but Horner syndrome is a characteristic feature. Then in this Wallenberg, there can be crossed hemianesthesia. It is because of 5th nerve palsy, cranial nerve 5th palsy की वजह से there is ipsilateral hemisensory loss of the face and lateral spinothalamic tract, which lead to contralateral hemisensory loss of the body. So but still the most important is the Horner syndrome. The clue. So in the question there were Horner syndrome. So it is the diagnosis for this is your lateral medullary syndrome, and we know that lateral medullary syndrome is the artery which is supplying is the posterior inferior cerebral artery, the pica artery. Now coming to the next, that is the medial medullary syndrome, which is medial medulla. This thing is also known as this Bridge-Ryan syndrome. Then the artery supplying is the anterior spinal artery. The only thing that you need to remember in this case, it is the cranial nerve involved most commonly is the 12th nerve, and there will be tongue deviation. There will be contractile hemiplegia, but the tongue deviation is the clue. That will be the clue in the exam. Now next is the coming to the pons. You have to remember one thing: in the pons, all the three supplied by the basilar branch. So this will never be the question. The question will be about the cranial nerve. In the Raymond, only 6th nerve is involved, so there will be contralateral 6th nerve palsy with cranial nerve 6th palsy ipsilateral and the contralateral hemiplegia. Cranial nerve palsies are always ipsilateral with contralateral hemiplegia. Whereas in Millard-Gubler there will be facial palsy with hemiplegia. So if there is 6th nerve palsy with hemiplegia, it is Raymond syndrome. If there is 7th nerve palsy with hemiplegia, it is your Millard-Gubler. So these two are the most important, the most confusing. Now coming to the last, if there is facial palsy but no hemiplegia, then it will be your Foville syndrome. That's it. Then coming to the midbrain, all will be supplied by your posterior cerebral artery, branch of the posterior cerebral artery. Now the important points again are Weber syndrome, which is 3rd nerve palsy and hemiplegia. Claude is 3rd nerve palsy with ataxia, and if there is tremor, then it will be Benedict. These are the clues which you have to rectify. Okay, so Weber syndrome is 3rd plus contralateral hemiplegia, 3rd plus ataxia, and tremor is Benedict syndrome. So this is the table that all the PYQs and the important questions are in this table. You have to read and revise it again and again so that you can learn this. Only the arteries which are important are these ones: pica, anterior spinal artery, and this PCA branch. Then another is the cranial nerve involvement. Midbrain always it will be the 3rd nerve which is involved. The most confusing is in the pons, because in the Raymond there is 6th nerve palsy, in Millard-Gubler there is 6th, 7th both, but there will be facial palsy will be more prominent. So facial palsy with hemiplegia is Millard-Gubler, and 6th palsy with hemiplegia is Raymond syndrome. Coming to the next question: which among the following is the most severe manifestation of CKD? So this is very simple. It will be hyperkalemia. We all know that. Now complications of CKD there are so many, but most important which you should know is the dialysis की जो indications है, they will be the complication like acidosis, metabolic acidosis, anuria, electrolyte abnormalities. We have already learned this mnemonic in the previous video. Hyperkalemia, which is the most severe. O for overload, that is fluid overload, which is pulmonary edema, and then lastly with you it is uremic complications, which are your pericarditis, gastritis. I have already discussed about this mnemonic in the previous video, and cephalopathy. Then next complication is increased phosphate hypocalcemia, which is responsible for the middle and bone disorder. Then anemia. Then other metabolic disorders like dyslipidemia, hypertension. So decreased GFR, increased creatine, all of these things will happen, but the most severe is hyperkalemia, which is or they can next time ask you which is the life-threatening complication. So it will be your hyperkalemia. Now coming to the next question: patient with massive abdominal swelling. Okay. Patient with massive abdominal swelling, we have done the paracentesis. Serum protein to be 3 and astatic to be 1. So here we are discussing about the SAG ratio. This is simple. You just have to do the serum protein minus astatic protein. So in this case it will be 3 minus 1, this is 2. So this is more than 1.1. This is falling in this category. So that means it is because of portal hypertension. Next you will check the astatic protein, which is 1 in this case. So it is less. So there are only 2 causes that you have to remember: cirrhosis and late Budd-Chiari. These are the most important causes that you have to remember: cirrhosis and late Budd-Chiari. In this case it will be late Budd-Chiari. If the protein would have been more than 2, If the protein would have been more than 2.5 in ascitic, then the answer would have been heart failure, or it can be congestive pericarditis. It can be early bird Chiari, IVC obstruction, or sinusoidal obstruction. The most important to remember is heart failure, congestive pericarditis, early bird Chiari. Then in the another one, if the ratio would have been less than 1.1, then it is non-portal causes, like it can be biliary leak, nephrotic syndrome, pancreatitis, tuberculosis. Now next important point that I want you to remember is about this. Metastasis to the liver leads to the high SAG, low protein, whereas metastasis to the peritoneal carcinomatosis leads to the low SAG. This is the important question which can be asked, which will be a very difficult question. So just learn how to calculate, then divide it into whether it is high SAG or it is low SAG. Low SAG is mostly biliary, nephrotic, pancreatitis, peritoneal carcinomatosis, TB. The most important cause of this is TB of low SAG. And with the low protein, there are two causes which you should remember. For cancer, this is different. Okay, that's all. Then coming to the another question. This question is not of medicine, but still, iritis is seen in all except. So here I have this table from the marrow. So here you have to learn that iritis is also an anterior uveitis. Anterior uveitis is seen in, so we will be learning the four important points: anterior uveitis, posterior uveitis, both, and intermediate uveitis. I will tell you only the important ones example which you should know. Anterior uveitis is seen in ankylosing spondylitis, juvenile RA. It is not seen in RA. It is seen in juvenile rheumatoid arthritis. So iritis is seen in all except, this is the answer. Okay. So psoriasis, SLE, leprosy. So iritis is seen in all except juvenile RA. It is never seen in RA. Then posterior uveitis is seen in this syndrome, Vogt-Koyanagi, and in all the infectious diseases like your toxoplasma, cysticercosis, coccidio, toxo, histoplasma, candida, pneumocystis, crypto, aspergillus, cytomegalo, any of the infection, cat scratch disease, there will be posterior uveitis. So as one syndrome and infections. Posterior uveitis is seen in one syndrome plus infections. Only 4 infections, which are your herpes, syphilis, Lyme, TB. These are the 4 infections which you have to remember, where there is both anterior and posterior uveitis is seen. This you have to remember: herpes, syphilis, Lyme, and TB. Okay. Then another important cause of both is Behcet disease. So Behcet disease, iritis is seen anterior as well as here anterior as well as posterior uveitis is seen. SLE, there will be only anterior uveitis, and about the IBD, again there is anterior plus posterior uveitis, where here you can see inflammatory bowel disease, either it is UC or it is Crohn's disease. Then intermediate uveitis is seen only in one condition, it is multiple sclerosis. So anterior uveitis is seen in 5 important causes: angstrom, juvenile RA, systemic SLE, leprosy, and psoriasis. Posterior uveitis is seen in one syndrome and one infection: Vogt-Koyanagi-Arada syndrome and infection, except for the 4 infection, which is herpes, syphilis, Lyme, and TB. Other causes of both anterior posterior is sarcoidosis, Behcet disease, and inflammatory bowel disease. Intermediate uveitis is seen in multiple sclerosis. Then this question was about a very important topic. A young male collapsed during playing football, that is any strenuous exercise. ECG showed V6, V5, V6 inversion, inverted T waves. You have to remember one thing, that in young with inversion of T waves, the very important cause at your level is atypical HCM or hypertrophic cardiomyopathy. And this sudden collapse history is very characteristic of this thing. In young patients, it is very characteristic of HOCM. Then echo is showing a septal anterior motion of the mitral valve. This is again characteristic of HOCM. Now, which of the following feature will be seen and what is the management of the patient? So this is very simple. In HOCM, you have to remember the beta blocker are the drug of choice, and we have to put the ICD in the patient. You just remember this. There is no need to. You just have to learn this. Then there will be the murmur about the murmur of the HOCM. There is ejection systolic murmur, and we know that the murmur of this HOCM, it will be increased on standing, and there is pulses bispherians, okay, in the HOCM. So about the murmur, the important point, this is a very difficult topic, how the murmur vary with the different phases of this thing. So on inspiration, all the murmurs of the right side, because in inspiration there is increased blood flow to the right side, so all the murmurs of the right side, they will be increased, and similarly on expiration there will be increased intensity of the murmur of the left side. Left sided murmur will be increased. Then coming to the hand grip. Hand grip increases the afterload. That means it increases the systemic vascular resistance. That means it increases the pressure against which the LV will eject the blood. So this will increase the murmur of all the regurgitant lesions, MR, AR, VSD, because more of the blood will now be going through the valves. Next, it will this afterload thing, because more of the blood, because there will be in cases of stenotic lesions like AS, there will be more pressure. See, this is, let's say this is the aortic stenosis. Already the area is very less. Now let's say this is the blood which is coming. This has to come out from this area, from the aortic valve. If there is increased pressure, increased afterload, so there will be more pressure in the left ventricle to outcome this resistance. So this will lead to the turbulence here, and the AS murmur will be increased. So in this is wrong. AS murmur will also increase in this case. In hand grip, all the regurgitant murmur and AS will increase. Now about the hypertrophic cardiomyopathy, what happens is afterload is increased, but in hypertrophic cardiomyopathy the cavity size is very less. So more pressure has to generate. The ventricle will not be able to generate because there is no cavity size is very little. So the murmur, there will be very less blood flow during this phase, and it will lead to very less murmur will decrease. Then coming to the next point on standing up, almost all the murmur decreases except the HOCM. Then on the squatting, again sweating increases the murmur intensity except the HOCM. That's you have to remember. That's it. Now coming to the next question. This is about the COVID patient. An elderly male was brought to you with a complaint of chest pain, tested positive for COVID. Now this is an old question, they will not ask this, but this is not for COVID, any respiratory condition like pneumonia. This is just a general question, in which case you will admit the patient. So any patient who is coming to you with tachypnea, respiratory rate more than 24 per minute. If there is SpO2 in the normal SpO2, patient is not able to maintain SpO2 of more than 94%. You have to admit this patient. Okay, you can see this. Moderate COVID was if the SpO2 is less than 93%. If there are multiple comorbidities which put the patient on the risk, then age. Again, age is the very most important comorbidity. So you can see that in the guidelines, the age more than 60 years, obesity, cardiovascular disease, hypertension, CAD, cerebrovascular disease, any active lesion, any CKD, CLD, diabetes, HIV, all of these things, and these few things, that respiratory rate is very high, patient is not maintaining saturation, patient is elderly, you have to admit the patient, but chest pain itself is not an indication. Okay, so this is the answer. This question will not be repeated again, I guess. Now next is the very important question again about the JVP, the correct sequence after the P wave. So here we will be learning about the concept about the cardiac cycle. So first you will have to learn about this thing, the JVP. There are 5 waves in the JVP. The first is the A wave, which represents your atrial contraction. And then second wave is the C wave, which represent the represent the bulging of the tricuspid valve into the right atrium. So in A wave, what happens that during the atrial systole, the blood is flowing from RA to the RV, following which there is isovolumetric contraction of the RV, or the basically ventricle isovolumetric contraction of the ventricles, where all the valves are closed but the ventricles are still contracting. So in that, because of the increased pressure in the RV, the tricuspid valve bulges. So this leads to the C wave. Then followed by which there is the X descent. Now here, why is this? Because ventricles, now the valves are open, so the blood will be ejected into the pulmonary artery and the aorta. So this leads to the decrease in the pressure, so that's why there is X descent. Followed by, again now there will be filling, the isovolumetric relaxation phase, where there will be atrial filling. So now since the valves are again closed, the atrias are filling, the pressure will be rising, so V wave, the increased pressure. Now coming to the last, again when there will be rapid ventricular filling from RA to the RV, the blood is actively going from the RA to the RV, there will be decrease in the RA pressure and there is Y descent. Now next point we have to know is about the ECG, all the electrical events are always preceded by the mechanical events. So we know that P wave is the atrial contraction, so it will be just before your A wave. So P wave of ECG will be just before the A wave of the JVP. Then QRS is the ventricular contraction, it will come just before the C wave of the JVP. Now after QRS, there is after C wave there is ventricular ejection, there is no electrical activity happening, so that is why there is this ST, which is a flat line. Now then after the X comes the V wave, which is the atrial filling, the pressure are rising, and this is isovolumetric relaxation, ventricular relaxation, or ventricular diastole. So ventricular diastole is your T wave. So that is why the T wave will be just preceded by your V wave. Then after that there is nothing, no electrical events till the next cycle. That's it. So P wave will be preceded by the A wave, QRS will be preceded by the C wave, and T wave will be preceded by the V wave. That's it. Now coming to the heart sounds, you have to remember that heart sound S1 comes just after the C wave, because S1 is by the closure of the AV valves. They are happening after the C wave, when the ventricular contraction had happened. Here the valves are closing, so S1 will be heard. Then next sound will be heard when just after the V wave, because now the relaxation has happened, the AV valve will the semilunar valve will close. So now coming to the so S1 will be just after the C wave and S2 will be just after the V wave. Now for the another sound, the S3 and S4, you have to remember S3 is heard during the rapid ventricular phase. S3 is basically increased hyperdynamic circulation. So when there is rapid ventricular filling, during this time if there is more of the circulation, so like in heart failure, or in it can also be seen in other conditions like anemia, pregnancy. So in these conditions there will be more of the circulation, more of the blood, so that will lead to the S3 sound. Then comes the S4. This is due to stiffening, and you have to just remember that it is just before the QRS. Now a mnemonic for you, for those who can understand the Hindi. The mnemonic is PA for पान की दुकान पर QR कोड स्कैन कर एक सिगरेट ली, then X-ray की finding आई V2 Y3. So पान for PA, you just remember 4 here, QR for QRS, then C1 for cigarette ली हमने एक, then X-ray की finding the X wave, followed by X-ray की finding was V2 Y3. So this is the point. So in our question we can see the correct sequence after P wave. So after P wave there will be A wave. Yes, there will be A wave. Then after that there will be fourth heart sound, that is not in the option, followed by which there will be QRS. So again they are not like this. Then there will be QR sports and secretly एक C1. So C wave they have not asked the first heart sound. So after A wave there will be B wave, then C1 followed by X wave they have not asked, then there will be V2Y3. So here your rapid filling of the ventricle is your Y, which is the last option, and T wave and T wave is represented okay, there is one more thing, ऐसे ये finding है TV2Y3. तो here it is TV2Y3. तो there will be T wave. तो answer will be A, B, D, C. This one. तो X-ray की finding will be TV2Y3. Okay. So that's it. Now coming to the second last question. 23-year-old male developed epistaxis which resolved spontaneously. The most important point. It is after the febrile period is over. The patient is afebrile for 24 hours. His platelet count is now decreasing, and now 14,000. BP is normal, but the hematocrit is rising. Now this pattern, fever followed by decreased platelet plus increased hematocrit. This is the characteristic of dengue. So the diagnosis is dengue. Now since there is also evidence of hemorrhage, so this is most likely dengue hemorrhagic fever. The four things you need to know in that for the correlate to dengue hemorrhage is the fever, hemorrhagic manifestation, platelet less than 1 lakh, and plasma leakage. Plasma leakage is identified by the three things, which is your hematocrit rise by 20%, more than 20%. There can be pleural effusion or ascites. Any condition which is the examples are the third space loss. Okay. So this is the diagnosis for this case is the dengue hemorrhagic fever. Now for this you have to know about that the treatment is fluids and observation. So answer in this case will be give plenty of oral fluids, IV fluids and observation. So 2, 3, 4. This is the answer. Now indication for platelet transfusion in a patient with dengue are only two: if the platelet is less than 10,000 or if there is any count with bleeding manifestation. In this patient the bleeding has already stopped. So there is no role of prophylactic platelet transfusion. Just remember this, platelet will be transfused when there is bleeding, active bleeding, patient is bleeding actively, or there is less than 10,000 platelets. Coming to the last question, about the KF rings, which of the following is true? This is a very important topic. Many times this is asked. The KF ring is the copper deposition. Every point is a MCQ. In the Descemet's membrane, in the superior and the inferior pole. The copper deposition in the Descemet's membrane, superior and inferior pole. It is seen in 90 to 95 to almost 100% of the neuro-Wilson's patient. If the patient is having neuropsychiatric manifestation, he will be having KF ring. But KF ring are not pathognomic for your Wilson's. The differential diagnosis are your PBC, primary biliary cirrhosis, PSC, primary sclerosing cholangitis, or any cholestatic condition. But still the most common cause of KF ring is Wilson's disease. In hepatic Wilson, only 50%, only half of the patient will have this KF ring. Best these are seen by the slit lamp. The color will be golden brown. Another important finding which you should know in the Wilson's is your sunflower cataract. Sunflower cataract is also seen in your Wilson's disease. Next, investigation of serum for Wilson is serum ceruloplasmin, which is the best investigation, which is decreased. And another investigation which is also important is the 24-hour urine copper. Copper will be increased, ceruloplasmin will be decreased. Treatment, we all know it is the penicillin. Plus minus we can give the patient triantine or the zinc acetate. Now in this patient we are having seen in all patient neurological involvement, yes. Pathognomic for Wilson, no. Resolved with desferoxamine, no. Treatment is penicillamine and not desferoxamine. Desferoxamine is the treatment for hemochromatosis, not for the this Wilson's. Seen in all patients with hepatic involvement, no in only 50% of the hepatic involvement. Seen in superior inferior pole treatment, this is right. So answer is only 1 and 5. So that's all about KF ring. You should know copper deposition, Descemet membrane, superior inferior pole, almost all patient neuro Wilson's. Differentials are PBC, PSC, cholestasis. Most common cause Wilson's, only half of the hepatic Wilson, best by the slit lamp, golden brown. Then also sunflower cataract is another finding. Investigation is ceruloplasmin, which is decreased, important. drug of choice is the penicillamine. So that's all. With this, we've ended the 2020 PYQ.